introduce you
Oh yeah.
from last time.
All right.
Yeah, that works.
Yeah.
Well, thanks so much, you guys. I'll give you the stage and you can go right ahead. We're really excited. Thanks for being here.
Thank you for having us. It's a pleasure to be here. And first, I'd like to introduce my panelists here. Dr. Danilo Sirius is a professor, systems thinker, and renowned expert in applying the theory of constraints to healthcare. With a PhD in business administration and a background in industrial and systems engineering, Danilo has helped transform patient flow in hospitals and clinics across the country. He's the co-author of Smash the Bottleneck and was named TOC ICO's Practitioner of the Year in 2019. Whether it's the hospital or the chessboard, he's all about strategy and results. Next guest, Dr. David Boger. Dr. David Boger is an emergency medicine physician and the site medical director at a high acuity hospital in Virginia. With experience leading trauma, stroke, and PCI care teams, David understands the realities of frontline medicine. He brings both clinical insight and strategic leadership to the conversation around patient flow, efficiency, and emergency care innovation. And last but not least, Dr. Benjamin Newman. Dr. Benjamin Newman is an emergency physician and managing partner at Healthcare Constraint Management. A seasoned leader in hospital operations with a master's in medical management, Ben brings a pragmatic, results-driven approach to improving healthcare delivery. With years of executive experience and a deep belief in the power of strong relationships, he's reshaping patient care, one constraint at a time. Thank you, gentlemen, for being here with me.
Thank you.
Thanks.
Yeah, thank you very much.
So let's start with Danilo. What exactly is TOC? Why are we talking about it here today?
Okay, so you got me first, eh? I figure I'm the teacher here, so I'm supposed to know. Well,
Exactly.
theory of constraint, the brainchild of theory of constraint is Dr. Ellie Goldratt, and the most famous book is The Goal, and it was written I think 40 years ago. So it's still a bestseller in many places and required book in many universities. And the theory of constraint has one basic principle. It doesn't matter how complex a system is, there's always very few resources that determine the output of that system. And so just having that as a theory, let's say, as a corollary or whatever, or axiom of the whole theory, everything else being developed. Because that means if you're managing a system, your first question is, in addition to what is the goal of the system, is what is the constraint of the system? Because based on that, managing those constraints will allow you to improve the system as a whole. I'm assuming we'll talk about more as we go, but that is the main axiom of theory of constraint. The idea that doesn't matter how complex the system is, out of all the resources you have, there are very few that determine the output of the whole.
So it seems like we have to find what to focus on essentially. That area of focus will determine the throughput or how many patients we can see, how much money we'll spend, what the actual throughput of the system will be. Ben or David, it seems like you guys have some stories behind how you first came about, can define theory of constraints and really what led to that journey. Like how did you think it would be related to being able to deliver medicine better and really see more patients and not have to increase costs doing it?
Yeah, absolutely. I can kind of take this one, at least the first part of it, Dave. So we kind of stumbled into theory of constraints several years ago. I was the executive medical director for our emergency department group, and we were right in the middle of a really significant staffing crisis. Like we had more physicians that were leaving than we could bring them on board to staff our emergency department. Um, and so, as we're, most, I mean, staffing is something that's super common. Staffing problems are super common across healthcare. Um, but kind of as we were coming, kind of like rapidly approaching being very short-staffed, um, Dave actually, I think you read the goal and you're like, oh my gosh, this is a totally different way of thinking about everything. Had me read the goal, and then we just, absolutely took off trying to kind of read and learn everything we could. And that, the kind of like Danilo said, the mindset, most people when they do process improvement stuff in healthcare or anything, they kind of look across like they kind of look horizontally, they follow like a patient journey from like the time they check in from the door until they like leave, which is kind of a very lean way of thinking about it. I think there's definitely some value, but it kind of neglects the fact that there actually is a resource within that system that is going to determine how your system functions, not just the unnecessary steps and kind of in a horizontal view, and that you can do things to actually manage to that constraint, to that resource. So we knew that our physicians, or our medical providers, not just physicians, were going to be our constraint. That even if we, leaned up the patient journey across the ER visit, decided on, whatever, less testing or less unnecessary stuff, we were going to bottleneck at the physician step every time, no matter what. And even if we were leaner, we weren't going to be able to produce any more unless we actively kind of manage what we knew was going to be our bottleneck. So for us, I think that it was a mix of having a crisis and then having a a philosophy that actually said, "Hey, you can do something about your crisis. You don't have to just accept the terrible situation that's coming at you." Um, was I think those two things together was like the spark that kind of got us into theory of constraints. What we ended up doing was, we ended up leaning on telemedicine and some kind of creative ideas to kind of expand the capacity of the physicians, and even offload some of the physician work outside our area, outside our individual, like our geography, to kind of basically offload that bottleneck. And if we get into like some of the education and kind of the basics of theory of constraints, we basically made our physicians kind of the best we could, the most important part of the system, in terms of helping them not have wasted time, wasted actions, wasted steps, that kind of stuff. That was kind of how we got into it, and then it's just kind of grown from there. Dave, anything to add?
No, I think you covered it really well. I think it's that transformative thought and knowing that you can do something to help speed patients through just by focusing on your bottleneck. We spend a lot of time in healthcare worrying about every little part of the system and doing projects at different areas. And you don't get out what you put in. You only get out what you put in your bottleneck. Actually, you get out more than you put in if you can find your bottleneck. So, like Danilo mentioned, the goal was huge for us. There was another couple books that we had read, and we did our own logical thinking trees to figure out where our issues were, redeveloped our entire front end, which is the triage system in the waiting room, and how we used it and applied it, with the idea of the doctor being the constraint or the provider being the constraint. And then Ben had launched a very quick project using some critical chain theories, which is another theory of constraints kind of generated idea, to get this telemedicine program up and running to help offload our providers even more. So once we saw the benefits, once we were able to read the book, understand it, and then apply the benefits in our own area, and just got us really excited to take it even further.
Can't help but notice that you guys are smiling while you're talking about this, which is odd because we're talking about organizational improvement and change management essentially, and things like that. Um, Was leadership involved in this, or like how did they respond to you wanting to do this in your department?
Um, yeah, that's a mixed bag. So part of us, I think we're probably smiling a little bit because it's kind of like knowing a secret that nobody else knows. like it's encouraging once you get it, and it's not necessarily complicated, but it's also not easy to get. Like you have to spend some time understanding it. But once you get it, it's like having all the pieces to the chessboard. I don't know, like in place. It's probably a terrible analogy because Danilo is really good at chess, but like it's like understanding everything finally, and not feeling like you are just a victim of your circumstances. Having some agency to actually fix stuff, and knowing what small actions you can take to actually make a difference. Um, the leadership response that we experienced it's interesting. It was interesting. It continues to be interesting, and I think it's interesting across every probably setting within healthcare. Um, I don't know. I don't know if this is universal, but um, healthcare is one of those things where I think leaders come from all directions. They get promoted into leadership from clinical roles. Some of them have business degrees. Some of them come from more like business backgrounds. And in theory, everybody kind of recognizes the truth behind things like theory of constraints. Like Danilo said, they mostly all read the goal. They understand the idea that you have to have some protective capacity. You have to, focus on a few things that make a difference. In actuality, at least in my experience with several different healthcare systems, there seems to be a very kind of lean thinking and trying to there's a little bit of a disconnect oftentimes between the little investment that it takes to invest in like a theory of constraints project and kind of what is common sense, even though I don't think it's what's taught in business school or what most people actually would say if they're like referring to textbooks, but what is common sense, which is a lot of people use common sense and say our nursing staff should be at 100% efficiency or our respiratory therapies should be at 100% efficiency, and coming and saying, hey, if your doctors are your bottleneck or they're the most expensive resource and so they should be your bottleneck, you have to have not 100% efficient. You have to have lower than 100% efficiency of your nursing or respiratory therapy or these things that support them, or else you're going to be wasting capacity at that level. So I say it's interesting because there's a little bit of in my experience, there's often a disconnect between what people feel pressured to do when they're leading their system compared to what theory of constraints, or even I think most business books would say is like good leadership practice. So our leadership for our projects was exceptionally supportive. Once we made the case and explained it, they gave us honestly, just executive support to make it work. Um, and then, but even since then, sometimes we get support, sometimes we get, difficulty kind of getting buy-in sometimes because it seems too outrageous that by increasing respiratory therapy to below 100% efficiency, we're going to improve the whole system. It doesn't like math sometimes, I think, to some people.
If I could piggyback on that, I've done so much thinking on kind of how this happens. Um, I think that everyone in healthcare and in leadership is intelligent and they want to do the right thing. I think that the spectrum that is the hospital is very large. So you have all these different departments. So what we do kind of logically to make that more easier to digest from a leadership standpoint is you put a leader in on top of every silo, let's call it, or every area. And then we have to, as humans, understand what makes somebody a good leader or not. So we usually use a metric to do that. And with everything being computerized and the ability to get data very easily, we tend to pick metrics that are like quote unquote efficiency metrics or productivity metrics. And when then we look at statistics, we use things like means and averages. So whenever you assign a leader to be in charge of a siloed area, and you give them an efficiency metric or production metric, and you give them the tools of means and averages, their goal becomes to make their siloed area as effective or as efficient as possible. So that means minimizing waste. Where that butts heads against the theory of constraints is if you have a lot of areas that are all attempting to minimize waste, then you have statistical variation, which just means different amounts of people run through that area at different times. Like if you look at triage in an emergency department, 20 people can show up in an hour. Now, if I'm trying to be very productive and I'm trying to use a mean or a median, the chance of me being able to take care of that 20 people an hour is very low. So it causes these backups throughout the entire system. It's not until you take this bird's eye view of the whole healthcare system as a whole and then realize it's okay to have providers, to have nurses actually sitting and not doing anything, waiting for work. That's very hard for people to do. And I think it comes from this the amount of data, the means and medians, everyone being siloed, and then dependent events, which means you have to go through triage to get your labs. You have to get your labs to get a diagnosis. You have to get your labs to get an image. You have to get a diagnosis before you can be admitted. So what we've done is we've constrained every little part of the system. We've tried to make it as efficient as possible, therefore limiting its ability to deal with variation. And we staff to means or averages, which means we're wrong if we're high. If anything comes in high, then we're already wrong. And then the dominoes all fall backwards into the waiting room. And then we look at the waiting room blow up as an emergency room problem instead of a system problem. And that's kind of what we've seen play out over and over. I don't think it's any person's particular fault. They're actually really good at managing the productivity of their area. And that's actually what gets us into the most trouble, ironically.
Well, yeah, but behind everything you're saying, there's just a philosophy of how to manage the system, right? Always try to compare and contrast. I mean, the leading philosophy behind managing healthcare at this point seems to be is two principles. One is cost reduction. How do I and we can call it whatever we want to call it, right? Reduce waste, whatever we want to call it. But at the end, is reducing cost. And the second underlying principle is optimizing each part of the system, optimizing the system as a whole. So everything that David was, all this KPI, all this that we're talking, optimizing my own place, is connected to those philosophy. So see, comparing and contrasting with the theory of constraint, it is in theory of constraint, the focus is increasing throughput. So we gotta get more output out of the system as opposed to reduce the input into the system, if you want to put it the other way. And the second is the idea again of the constraint. So instead of optimizing everything individually, we optimize the constraint, and everybody else works to support that constraint. And that's, I mean, we use a different language in TOC, but basically that's the idea. Identify the critical resource, which we call the constraint. How do you optimize it? And then all the other resources have extra capacity, protected capacity to support that resource. And that's not what is happening in many places, right? Like David was saying, okay, I have my resource, I don't know, are the cleaners, okay? How can I do more with less? Okay, whatever it is that they do. And at the end, they don't support the constraint and the flow stops and throughput stops. And that's the difference, comparison and contrasting of the normal way to do it and what we suggest in theory of constraint.
So it's interesting. So first, I think that's probably like the top things that current systems miss is to actually identify the constraint from what you guys have, all three of you have said, right? In terms of let's optimize everything everywhere and cut costs and call it a day versus, okay, well, if you do that, you're actually hurting the system because you're not actually optimizing for where they can, like, if you can only see 100 patients a day, because you have so many providers in the ER, and that's where you have to, and that's the constraint that you have to optimize that first. You have to, if you want to increase the amount of patients you see, you have to address that part of it, right? If you want to see 150 patients a day, then you have to, so optimizing everything else won't help you. You're just kind of wasting time and effort essentially. So I want to ask you, with this in mind, oh, go ahead.
Well, not only will not help you, it will hurt you. Okay,
Yeah.
you have to say exactly what happened.
Absolutely.
Okay, yeah.
Yeah. So with this in mind, because doing all of this also kind of makes people burnt out and feel they're not really valued because they're just kind of like, cogs in the machine, so to speak. And then, uh, it's like a productivity engine, parts of a productivity engine, if you will, and not like, kind of to be disposed of as, if they become unnecessary or too expensive versus, I love, having talked with Darlene, the concept of, caritas and essentially treating people as people and not just like pieces of machine. It sounds like theory of constraints and what you guys have done in the ER has helped bring back that kind of pride and joy, if you will.
Yeah, I would say like there are hospitals that do this well, and when you like kind of peel back the layers, they have mantras like patient first. And I think that those kind of mantras are those hospitals that are really putting all of their worth and their value into patient care. These decisions actually become easier. Do you call in a physician for extra pay at midnight because there's patients to be seen? Like the answer becomes yes very quickly. Um, and they get that throughput benefit, and then they get more prestige and usually do well financially, and then they can continue kind of that whole mantra, and it becomes self-sustaining. When you have hospitals that run on very small margins, actually most, if not all of them do, um, then you have to start deciding if I make a financial decision, I still have to take care of the community that I'm within. If my hospital kind of collapses underneath me, it doesn't help anybody. But then it tends to make this efficiency, productivity, more financially driven decision, and then that leads to actually worse finances, ironically. But that whole idea of having like a mantra or patient first, there are hospitals out there that have that, put a lot of stock in that, and then that's actually kind of a flow mantra in and of itself, um, just like theory of constraints is.
I would say too, I mean, for even just um, this is something that like most frontline staff get. Like maybe not like all the details, but like I'm trying to watch the chat as well. It's a little bit hard while we're talking, but I saw some of the comments about like, you know, about kind of like patience and being about people and stuff. And like if you go to your frontline staff, like they know that when they're spread thin or like just barely covering, on paper, whatever the need is, that they recognize they're not taking very good care of patients, or they feel like they are being asked to provide suboptimal care. That this idea of things being, exactly kind of trimmed or cost savings, that kind of stuff. Like the frontline staff knows that there has to be some capacity buffers to actually do a good job, and to feel proud of like what they're doing and stuff. It's funny because your frontline staff typically gets this um, intuitively, whereas the intuition seems opposite oftentimes from kind of a leadership perspective.
So it sounds like from what you're saying is, um, it's it's possible to have a well-functioning system or a well-functioning team that's um, meeting not just meeting patients' expectations, but exceeding them in terms of like time and quality of care, concern, um, and the ability to show essentially love towards your colleagues and the people who work at the hospital or the department in terms of treating them well, making them feel valued, and so you can have the efficiency and like a love-based culture, essentially, where like a culture that makes people feel safe, makes them feel valued, and makes them feel productive at the same time.
Yeah, I think Ben probably says this better at agreeing with the love, but also on the terms of removing suffering from people seems to be what we believe is the goal of healthcare, and that includes the clinicians and everyone who works at the hospital as well as the patients. But somebody waiting in a waiting room for 12 hours, clearly that's suffering, not able to get to your primary care appointments or get your medications. That's a form of suffering. Whenever you have physicians or providers that are struggling under the weight of the patients that they're to see, that's another form of suffering. So, um, the idea that you can improve everyone's suffering and try to decrease that with throughput and with flow and with theory of constraints is also uh, very appealing to us. And we did a theory of constraints conference on healthcare, and Ben had done a fantastic opening talk that was based around this idea of removing suffering and kind of what it means to be a healthcare institution.
Well, I mean, as you mentioned in my bio, my background is in engineering, so I started in manufacturing, but then later I moved into healthcare, and it was a great surprise for me to work with people in the industry because they really, really, really care. It's completely different environment in manufacturing, to the point that some of them, sacrifice their own personal health to help to other. I've just finished a project with a grant in behavioral health, and that was my impression. And as I work more and more in different areas, this is what I found. Okay, so it's great to work. It's great to work with this for people. But what theory of constraints provides, though, it goes beyond the wishes, right? That it will work this way, and it provides you a roadmap. I mean, it's a roadmap. This is how you go into a healthcare system and get the improvements that we got. We have this conference that David mentioned, and you see all those improvements of 30% more throughput. I mean, I see it more from the perspective of engineer, right? 30% more throughput, but everything translating to less suffering for patients and more satisfied frontline people, and that's great that we can provide that roadmap.
Yeah, one of the one of the themes that comes up a lot of times as you're learning about theory of constraints is moving from basically firefighting, which is a term that's used in a lot of like the books and the education, to being intentional, and the idea that you go from literally just running from fire to fire, trying to just put out the next biggest fire before your house burns down, um, versus something that is much more reliable and controlled environment. In healthcare, there's different layers of suffering, and I agree with what Dave said. Our purpose in healthcare is to relieve suffering. No, we don't ever, at the end of the day, really save anybody's life. We don't, the only thing we do is relieve suffering, and the kind of the most suffering that someone can experience is an unnecessary death or some unnecessary, morbidity or mortality that could have been prevented. And then if you work your way back from there, there's just layers and layers and layers of pain and fear and anxiety and waiting and discomfort, that people experience all up into the point of that kind of worst suffering possible of, losing a loved one that you didn't have to lose. Um, when your house is on fire, you end up spending all of your time just on the biggest fires. And so, there's a lot of value in healthcare and being able to sit down and talk with people or make connections with coworkers, or, all the stuff that's all those layers of suffering that you can actually address if you have time to. But when you spend almost all of your time just doing, kind of firefighting stuff. Um, I guess the softer skills of like love and compassion and caring and some of those things that really, make healthcare just wonderful and make our relationships wonderful in healthcare. That's the first thing that goes because you end up spending most of your time just trying to prevent a disaster. Um, that is, in my experience, a lot of the way that healthcare functions right now is people just spread too thin that they don't even have any capacity to invest in kind of the soft but enjoyable skills of healthcare that also relieve suffering. That is also necessary as part of our job as doctors and nurses and respiratory therapists and administrators. Um, that's where I think to connect kind of theory of constraints to the purpose of this conference, the compassion and loving people and stuff. I think the theory of constraints helps you produce a high reliable system, a high reliability system, and moves you from firefighting, which is, a little bit compassionless because it has to be, to having the capacity to actually do a good job with the entire spectrum of investing in people and relieving suffering.
So with that, for the people who are taking care of patients, what reactions have you seen from them, or how, like, as you've seen, since you guys have been kind of at the forefront of implementing this at your hospital, what changes have you seen in the staff in terms of their actual like affect and approach to things and morale?
That's a very hard question to answer because um, at the hospitals we've done this at, I would love to say that it it got a ball rolling that just, kept going. Um, I've not honestly consistently seen hospitals kind of stick to what what we would encourage them to, and you know move from kind of a firefighting high efficiency organization to a compassionate high reliability organization, um, in general. So I have a hard time honestly producing a good example of like how the staff in general improved. Um, that is one of the very difficult things about theory constraints is it seems that it's constantly swimming upstream compared to just whatever common sense is. And every new project, every new leader, you're kind of it's very easy to I guess undermine and undo if somebody doesn't completely understand it. That's my more discouraging answer. Hopefully, maybe Dave or Danilo has a more encouraging answer.
Okay. Well, I don't work in the emergency department. Okay, so I cannot talk about that. But I mentioned a few minutes ago the project in behavioral health, and it's interesting because as we were preparing uh, the principles and teaching people, some of the counselors would say, "Oh, when we went to school, they told us that we were going to be most of the time doing paperwork. They warned us of that." And I said, "Really?" I said, and they said, "Yes, that's what they taught us in school before we go. Be prepared. I know you care about patients and counseling, but be prepared that most of the, no most of, but big portion of your time will be doing some type of paperwork," which for me is sad just to think about that, right? So I mean, we went through the process theory of constraint. We removed everything we could from the counselors, and uh, and it was interesting because when we were talking, we always start with which is our mission and our vision as an organization, and it's always reducing suffering or improving people's life, something of that regard. So they all feel behind that. Okay, so when we said, okay, this is the philosophy, we'll have the counselors are the constraint. We need to remove as much as we can from them so they can take care of patients, more patients. Everybody was happy. All the front office said, "Yep, we can take that." Oh, you want to write this letter? We do it. Don't worry about it. So you have this. I mean, if you train people the right way, and always have but take into account the mission and the vision of the organization, you get the sense of cooperation and everybody. Okay, yeah, we're gonna take care of more people, right? Just give me that letter, give me that little paperwork. I can handle that, and it's just different when we apply TOC. Now we have, and again, we have this conference a few weeks ago where you have all these examples of people describing exactly what I'm just saying. I don't know if that answers your question, Sam, but
Well, I mean, so to me, it seems like the theory of constraint really centers around helping the people who aren't in the C-suite essentially feel empowered, like people in the trenches, for them to actually be the kind to um, have more decision-making capability and kind of see more of the I would say impact um, or at the very least feel more like they're more listened to because people, since they're the ones who kind of see exactly what's going on. It's kind of like for a field for a general in the war, and if he doesn't take a look at listen to his subordinates remarks of what's going on in the field, in the in the trenches and in the battlefield lines, and just makes decisions based on a map or what have you, he's going to make really long, he or she's going to make potentially suboptimal decisions because they're not taking into account the actual accounts of the people on the ground. In the hospitals, it's the same, similar in terms of like if the C-suite makes decisions that don't take into account what people are actually seeing on the ground, for instance, not really understanding what the constraints are, or uh, the morale, or how people are feeling, then they're going to make really bad decisions potentially that will hurt uh, the hospital and how it takes care of patients. So I guess my question is, um, in your experience, have you seen that's the case in terms of has theory of constraints been able to help uh, the people on the ground have be more heard and feel like they're more heard?
then David.
I wouldn't say so much for us, but we're a small part of a big system. So uh, I think that the nursing and physicians that we work with, um, and the changes that we've instituted in the emergency department, they all understand. And if you tried to revert that on them, they would quickly see that that would be going in the wrong direction. So they all kind of appreciate that and understand that flow is important for patient care, and that what we're doing right now, even though it's not optimal, is very helpful for seeing the patients that we have in front of us. But I think from uh, kind of a general, you're correct in that there's probably not enough time spent in these areas to understand the problems, and trying to fix a problem you don't fully understand puts you at risk for an incorrect fix. I think one of the take homes should be that the system is actually operating exactly how it's designed to. Um, and sometimes you have to look in the mirror at the designer and figure out how you're going to fix it. But a lot of times there's a lot of finger pointing whenever there's really no need. It's like these false assumptions and these metrics that get us in trouble, not the people working. Um, so kind of looking in that mirror and saying the system isn't operating well, it's probably because we've designed it. So let's look at the design of our system and actually critique that, instead of critiquing the people. Um, and I think that would get you a lot more kind of buy-in from your frontline folks, and then also help improve your flow at the same time.
Yeah, surprisingly, and this is what I was saying earlier, your frontline folks actually um, they don't need it as much, honestly, as your managers do. Your frontline folks, I mean, they know exactly where things are broken.
Mhm.
I mean, kind of to what you're saying, like if anyone's ever had this experience of, something terrible happening in their waiting room, because there were no beds to put a sick patient in, it's never because we didn't know that there could be a sick patient out there. It's because we didn't have the staff or the beds or the resources. And so if you go and you ask, your charge nurse, hey, why did this bad thing happen in the waiting room? Why did this person who was obviously sick have to wait so long? And they'll tell you, because I don't have enough nurses, and I don't have enough, or I have enough nurses, but I don't have enough respiratory therapists, or I don't have enough, cleaners to turn the beds over. And so I'm waiting on beds upstairs, or whatever. They'll direct you directly to the problem. Whereas many times managers or administrators, whoever, will come and say, oh, we're going to make a new policy that none of this, type of patient sits in the waiting room anymore, but it doesn't actually fix the problem. Whereas your managers need to invest in understanding kind of system thinking, and things like theory of constraints helps them actually understand where the bottleneck in the system is backed up and caused a problem, upstream, um, with whatever happened in your waiting room. Um, I will say, to like, how does this empower people? When we did our first project in theory of constraints at our hospital, what we identified is that our physicians were going to be the bottleneck, and that at the same time, our beds were going to be a bottleneck. Like, we kind of changed our thinking to be kind of like staffed beds, or um, enough beds that like staffed with doctors and nurses, even though we had enough nurses. And so when we developed kind of all of our other strategies, one of the things that we did is we said, let's preserve our physician time and our bedtime. And we decided to intentionally keep people in the waiting room longer, longer than we would need to. So if you come in and you got, a CAT scan of your belly and we have an open bed, we didn't put you in that bed until your CAT scan results had come back. And then the physician's time and the bedtime was used most effectively, because it could actually move the care forward. We had the results, we were ready to move forward. Um, and what this did is this basically preserved our bed, so that when we had a sick patient come in, um, we could get them in a bed right away, because we always had bed open. And the total time in the department started to decrease, because we didn't end up with this kind of congestion syndrome where everything was congested from people just sitting in beds waiting for their results. Um, Now our culture, like, if you try to take that away from our nurses, it would be mutiny. Like, we cannot like, they are so convinced of the benefit of flow by, like, identifying what your bottleneck is and preserving that resource, and not letting it be low utility or low use interventions, that, I mean, you can't get them to put a patient in bed who's not ready for a bed, because they just recognize that it just takes up some critical resource that you're not actually improving the system with, or you're not moving anything along with. It's very counterculture to, especially like lean, which says you should put a patient in a bed right away, and um, cut out that wait time, which seems unnecessary. But it actually, from a systems perspective, helps us helps us tremendously kind of preserve resources, preserve our bottleneck. And so our frontline staff is very convinced now of that, and advocates really strongly for that kind of stuff when which doesn't make it took a long time, not for our frontline staff to get it, but for kind of the next levels of management. And they let us do what we want now, and it works really well.
Well, it's interesting. I didn't know what just Ben did, that talked about, but it is one of the things that is counterintuitive, right, in terms of how you normally manage a healthcare system. But from the point of the theory of constraint, it just makes sense, right? If your bed is your constraint, you want to make sure a patient that needs the bed is in the bed, right? And I mean, it's just a series of things that, because I know I'm not an emergency, but I know I heard the term pull until full, right? Right? I don't know if that still exists, but it's basically push all the patients in a bed until it's full. And that's just the way. Well, it's the efficiency technology that dominates hospital, and until we can change that, we're gonna keep getting the results that we're getting.
And we have a question from the audience as well from Caitlin asking if we have any white papers, articles, or something else that we can talk about for the audience to look up or that we can provide for them to learn more about the topic.
Yeah. So it looks like that comment is directly under the talking about like how we phased our beds and stuff. So I don't have an article or white paper. We can I got to figure out, we can come up with something for sure to kind of explain it. We presented this specifically in the context of theory of constraints, kind of what we did at the TOC ICO International Healthcare Conference, where we explained it. They hold all those videos, although me and Dave have the original recordings that I believe that we're allowed to release. So we can get you something for sure. Dave, in addition to kind of explaining what we did, Dave has a really great presentation on our ER design. I don't know, Dave, you want to talk quickly about our ER design, but they kind of go hand in hand with kind of what we did and what we're doing.
Yeah, so there's a whole long presentation on it, but essentially we had the opportunity to build a new ER, and we thought, how do we build it with brick and mortar TOC built into it so you can't get away from using kind of that philosophy. So we did that. One of the important things we did is we called this area that we made up called a care initiation area, which essentially means after triage, even if there's not a bed, while we're getting a bed ready for you, you can still get medications and pain medications, and while you're waiting for your tests, so you can get the theory of constraints benefit of time in your bed. So you go into a bed when you need a bed, as well as actually receiving care instead of being in a waiting room in a much comfier kind of zoned area with like a personal TV and recliner, and you have a nurse that can do IV and pain medication, all that stuff there. So we've incorporated into the new ED, which is being built currently. So really excited to see how that works for us.
It's kind of like a high resource waiting room area. It didn't the big benefit from a cost and building perspective is it didn't count against our beds. So we didn't have to decrease the number of beds that we were building to basically build these like kind of waiting pods in the kind of in the just behind triage where people could start their care and get, like Dave said, IV fluids, their meds, wait for their CAT scan. Kind of people who needed stuff but weren't quite ready for a doctor yet, they could get that started. And it didn't count against our square footage cost to like build another room or something.
Cool. Well, thank you, gentlemen. I think we're out of time for today. But I love what we talked about. Hopefully, the audience found it useful. And Valerie, thank you so much for having us.
Thank you so much. This was so important. And thank you so much, you guys. Really appreciate it.
Thank you for the
Yeah.
opportunity. It was a good
Thank
time.
you for having
Thanks
us.
for having us.
Thank you.